non-rhinoviral viruses that can also cause colds and coughs in children. And many a times, some parent will come to you that the color of the nasal discharge is now becoming yellowish and thickish and green. So, it's the color of the nasal discharge is related to an increase in number or enzymatic activity of the polymorph nuclear cells which have infiltrated that area, and it is not a marker of a bacterial infection. So don't go by the color, go by the other well-being of the child to decide whether you need to treat it with an antibiotic or not. So definitely not a bacterial superinfection always, or an acute bacterial sinusitis, right? But if you have a persistent clear discharge and that is causing the child to cough as well, then you need to look at a bacterial sinusitis. You need to look at allergic rhinitis, non-allergic rhinitis, or do not forget a nasal foreign body if it is, especially if it is unilateral. And I do remember a child who had come to me with 2.5 months of cold and cough. And when child came close to me, I could get a very foul odor. And then I looked at the discharge was coming only from one nostril. And lo and behold, I found a large foreign body sitting in the nose, which was forgotten. Now, 2-year-old Ishan, he has fever and cough for 2 days. No history of frequent coughs, no history of frequent coughs or too much coughs in the past. But this time he's coughing too much. His throat is mildly congested, his chest is clear, and he has received all the possible cough syrups, antibiotics. And now she has come to you. The grandmother brings the child. She always comes say, "Normal doctor कडे गेले आता तुमच्याकडे आले." I keep telling them की मी abnormal doctor आहे का असं. I always ask them and joke with them. Okay, she comes to you on day 7. She says काहीच फरक नाहीये, इतका औषध केलं पण काहीच फरक नाही. And the one way of distinguishing whether this cough is really a problem or not is you quickly ask the mother, is it so bad that it's going on for 1 week? And you ask that the child is eating kahes khat nahi. I said then we should get them admitted. Then quickly they will come up with the answer. नहीं नहीं ये तो पहले था cold cough. It got better and now last 2 days it has started again. So what I'm trying to get at is try to differentiate between recurrent and persistent, because how you would approach a persistent rhinorrhea and cough is going to be different from how you will approach a child who has got persistent cold and cough. Also, you must understand that these runny noses, congestions, cough because of a viral illness do take up to 10 to 14 days to get better. And as long as it is a downward trend, the fever is coming down, the cold cough is reducing, maybe it's become a little more thickish rhinorrhea, we don't have to worry about it. We only need to counsel the parents. If you have a up and down course, meaning one episode and the child is better and gets again, recurrent is generally viral. If you have a cold and cough which is worsening over the 7 days or 14 days, that is the time I would worry. I would think of other things like tuberculosis, maybe a bacterial sinusitis, which is possibly causing worsening of the cold and cough. Let's look at another case. A 4-year-old boy who came with cough since 2 weeks, and this was recurrent cough since 1 year, almost every month. He responds to nebulizations. He had mild fever. Mother says he's not gaining weight, but there was no cox contact. The father was a smoker, and grandfather had asthma. So you have two triggers here: father, a smoker, grandfather had asthma, and mother is worried about the weight. And child is, this time though he has come for 2 weeks of cough, but it's almost recurrent every month since a year. When you look at the child, he's not sick looking, he's afebrile, upper airway. Please do not forget to examine the upper airway. Upper airway was normal, no pylorictal cyanosis clubbing, air entry bilateral equal, but he had a wheeze and other systems were normal. So you're clearly looking at a child who's wheezing and probably has got recurrent cough and wheeze, which is over a year. And typically, this is a kid who comes to you with a Mantu having been done. Fortunately, the strength was mentioned that it was a 2 TU Mantu, and here it was 10 millimeters. CBC was normal. ESR, like how it's like I call ESR a politician, kabhi idhar, kabhi udhar. And if you have a ESR of 35, 40, 50, you don't know how to interpret it, right? So ESR of 34, and this was the child's X-ray. Query doubt that there's some hilar congestion. Don't know if this was a lymph node on the left side. So this was what the child came, and 10 millimeters. So nowadays we do not do a Mantu test for diagnosing COX. We need to definitely look at a microbiological diagnosis. An ESR of 34 doesn't tell you anything. A plain X-ray, unless very classical, like a large lymphadenopathy, a cavity, an effusion, probably will tell you probable tuberculosis and not definite tuberculosis. Okay. So for any child who comes to you with cough, ask. And this is something, the 10 commandments, which all of us will speak about. A type of cough, nocturnal or not, how much time does it take to settle down? Does it respond to bronchodilators? Any triggers like weather, like exercise, like tobacco, or you've joined a daycare? How's the child between symptoms? How's the weight gain? Any personal history of atopy or a family history of atopy and asthma? So these are questions, if you ask, you will have a very good idea which way you are heading. So this kid, it will be called asthma if it is recurrent, the cough is dry, the cough is nocturnal, increases on exertion or exposure to triggers. If it is accompanied by wheeze, because cough alone may not be asthma, and cough accompanied by asthma, wheezing, which is again recurrent, which is more nocturnal, increased by exertion or triggers, then once and occasionally the child may be breathless. It's not necessary all the time, but you may have breathlessness, which could be again nocturnal and worsening on exertion. Anything which limits the child's activity. The child does not want to run or does not want to play or tells the parent to carry him all the time and tires easily. These are, of course, when you will think, when you have these kind of symptoms and these are afebrile episodes, when there is a family history of asthma and allergy, we need to think in favor of asthma. Mind you, asthma is a clinical diagnosis. So then look at the child. Look for allergic markers like atopic dermatitis, allergic rhinitis. Look for the demimorgan lines below the eyelid. To look for the allergic salute. Ask for history of sensitization to aeroallergens or food allergens. This is how you would come to a conclusion of asthma. Now let me take you through another case, and I think Abhinaya will talk to you more about wheezing in children. So I'm just sensitizing you. I'm going to leave her to get you into a little more details. Now, 3-year-old with history of nose block, cough on lying down. Here there is mouth breathing. Parents complain that his breathing is noisy and restless, and he's restless in sleep. So again, this is a kid who has nose block and cough only when he lies down. He when he goes off to sleep, he's not coughing. When you examine such a child, you find a nasal twang. Okay, when you hear his voice, you feel as though somebody has squeezed his nose and he's speaking. And if you look at his mouth is hanging open, and he has got something called as the adenoid faces. Do not forget to see the palate. A high arched palate is a marker of mouth breathing. Look at the size of the tonsils. Though size may not be a marker of severity of obstructive sleep apnea, but presence of large tonsils is going to make you think in favor of that as the reason for a postnasal drape or a obstructive sleep apnea which is causing them to cough. And look at the chest. So this kid's chest was clear. He had large tonsils. He had high arched palate. He had a nasal twang, adenoid faces. So these are markers of allergy. Please try and look at each and every child. Look at allergic shyness, meaning these are kids who have dark circles under the eyes, and they look shiny. So these are your allergic shyness. Look for creases below the inferior eyelid, which are called as demi-Morgan lines. These are all because of the obstructive airway down there, and then you have these lines which you can see, the fine crease-like lines. Bogginess of the lower eyelid. Look at the allergic salute that this kid is doing here. When he keeps on doing it, he gets a line on his nose. You look at if the nasal mucosa, the posterior pharyngeal wall, if the mucosa is pale, nose block, rhinorrhea, and also look at the pharynx, which may appear cobblestone. So these are markers of allergy. But you may have children who are mouth breathing, snoring, head bombing. Look at the size of the turbinates. Look at the size of the adenoids, if you can make out by the nasal twang. And in some children, you have obstructive sleep apnea. You may need more investigations like a polysomnogram, a sleep video, and you may want to look at the nasal polyp. Okay. Now let me look at another case. 18-month-old with history of breathlessness since 5 days, and he has been taking nebulizations locally. One previous episode of fever with breathlessness he has had, and the third episode was sudden. And then he became started coughing acutely and he was breathless and he had no fever. And bronchi were heard on one side only. So single side symptoms, though he has got history of recurrent wheeze, you would tend to think that this is one more episode. But what is different in this episode that this is sudden onset and it is wheeze on one side. So this was the X-ray. So typically you see an obstructive pattern here. So you see an obstructive emphysema on the right side. You also see a shift of mediastinum. You can see the trachea and you can see the shift of mediastinum to the left side, and you can also see the collapsed lung here. So this is our classical findings of a foreign body. So, what are the symptoms and signs of a foreign body aspiration? Sudden onset, ask for history of choking or aspiration, typically eating nuts. We had a patient recently who was eating nuts and his father suddenly came from outside. Father rang the bell. The child was so excited, started laughing, and here went the peanut into his lungs. If it's localized signs, but sometimes it can be bilateral, and sometimes the signs will show you that the air entry is completely absent on the side of the problem. Recurrent symptoms of choking and aspiration may sometimes not be witnessed. If you had symptoms of aspiration and if you get a history of choking, great. But if you do not get history of choking, so also you must have a high index of suspicion if you have all the signs and symptoms which I've listed. Sometimes the X-ray may be normal because it may not be completely occluding the airway. Okay, so if you're in doubt, you should do a bronchoscopy, and there are records of a patient having a forgotten foreign body inside for more than 25 years and it has been undiagnosed. Just 1 second, please. Okay, yeah, that's it. So 15-year-old boy, I'm taking you through a next case. 15-year-old boy with a history of cough, weight loss for 15 days. And he had fever since 3, 4 days, no cox contact. So if you have a 15-year-old boy who has cough and weight loss for 15 days, the first thing that you think in our country is this is a typical age, you think in terms of tuberculosis. But he had no history of cox contact. On examination, he was febrile, but his vitals were stable. Air entry was bilaterally equal. He had Krebs in the left upper zone. So, fever, cough, weight loss, and Krebs in a localized area. So, clinically, we thought we are heading for tuberculosis. And this was his first x ray, which was taken. And you will see here that probably there are some glands here. You see some kind of cavitation, cystic kind of lesions on the on the left upper lobe. So the first thought was there was no cox contact. We did a course of antibiotics while we were investigating this child to rule out tuberculosis. After 7 days of antibiotics, the X-ray almost looked the same. There was no change at all. Okay, and in the meantime, his investigations came in. His ESR was 110. Counts were essentially normal. We did a sputum because he's a big boy for AFP, which was negative, and gene expert was negative for AFP. Now, when we don't have a microbiological diagnosis, now we need to investigate further and a very, very high ESR. So we did a CT. We thought maybe we may need to do a CT guided biopsy to rule in or rule out TB. But the pattern of the pulmonary window was a little odd. There were a lot of cystic changes, which is not very classical of TB. And we could see lymph nodes here, but the lymph nodes were not showing central necrosis, which is quite characteristic of TB. So these were lymphadenopathy without central necrosis, some cystic changes in the lung. We thought maybe we need to do a biopsy to come to a conclusion and diagnosis. Though TB can come without central necrosis, but generally it comes with central necrosis. So we did a CT guided biopsy and it showed the presence of Reed-Sternberg cells, which confirmed the diagnosis of Hodgkin's lymphoma. So always think beyond TB, and when you have a persistent cough, think for a condition which could be more chronic or which could be more significant. So this child had persistent cough, no response to treatment. There was weight loss, and CT scan was not characteristic for TB, and therefore we needed to do a biopsy to come to a diagnosis. Now another case, 3-year-old, persistent cough, mild fever since 4 weeks. Treated with bronchodilators, cough syrups, but coughs continued to be persistent. So, despite giving cough syrups and bronchodilator, this child's cough did not stop. There was no cox contact, no asthma, atopy, or any other systemic involvement. All right. Mom thinks that the cough is a little chesty. Now, this is a 3-year-old who's been now coughing almost for 4 weeks. When you have cough which is going on for 4 weeks, you can't take it lightly. And if you remember, I told right in the beginning that any cough which is going on for more than 3 weeks is considered as chronic cough. Okay, so here is the thing: you can't take it lightly, and you definitely need to investigate further. Okay, now this child had a normal growth and development. He was not tachypnic. Saturation was 98% in room air. There was no clubbing, and air entry was equal, and he had scattered Krebs and Ronchi. But so it was bilateral scattered Krebs and Ronchi, and other systems were normal. All right. So this is a child you are looking at who has some signs and cough which is going on for 4 weeks, but he is not failing to thrive. Nothing. Right. So we need to really look into this child what is happening. So we thought whether it's tuberculosis in our country, we always need to think of TB, any other suppurative lung disease because this child had a wet cough. All right. We need to look at a protracted bacterial bronchitis. I will talk to you about it. Mucociliary disorders, immunodeficiency. But this was a well child till 4 years. Why suddenly we should think of immunodeficiency? We need to think of any aspirations which may have occurred, recurrent pulmonary aspiration, which is causing the child to have persistent cough, or we need to think of a retained inhaled foreign body. But again, things which were against the retained inhaled foreign body was they were bilateral signs. So these are the differentials that you need to keep in mind. So based on that, we did investigated this child, and so we could not find anything on CBC, ESR, MAN2. Then we gave a trial of antibiotics. After giving coamoxiclav for a period of 1 week, the child started feeling better, and we continued antibiotic because here our clinical diagnosis was protracted bacterial bronchitis. So, what is this entity called protracted bacterial bronchitis? I would just go to the next slide and then come back here. The diagnostic criteria for protracted bronchitis is bacterial bronchitis is chronic wet cough for a duration of at least 4 weeks. Mind you, it has to be 4 weeks. Absence of signs and symptoms of any other underlying disease, and you see a perceptible improvement, at least 40-50% improvement even within 1 week of giving the appropriate antibiotic. And the drug of choice here is coamoxiclav. Right. The reason why coamoxiclav is the drug of choice is because the pathogens are either H. flu, Streptococcus pneumoniae, or Moraxella catarrhalis. If you do a bronchoscopy and a BAL to diagnose these cases, the colony count should typically be more than 10 raised to 5 colony forming units per ml. But generally, it's a clinical diagnosis. You really don't need to do a bronchoscopy BAL, but once in a while you will do it if your diagnosis is not clear. An entity called as recurrent PBB is more than 3 episodes a year, and there you may need to do a bronchoscopy. Okay, so typically you will do only a bronchoscopy when you do not have a clear clinical answer. So in this kid, we had to do a bronchoscopy because he did not respond very well. After 1 week, he did respond, but his response was not as much as we should have thought. So we did a bronchoscopy. We found a lot of mucus plug into his airways, and he responded because he had a resistant bug. And after changing antibiotics, he got better. Now we have this is a 6-year-old girl who gets cough on and off. He has received bronchodilators in the past, and now has come with cough since 2 weeks, but in very short bouts, more in the day. History of COVID in the father. This is a kid who came just around the COVID time. Now the father was better. This is a well child, ENT normal, chest is clear. So you see this child. I will play the video. I hope you can hear, or you can at least see. If not, I don't think I shared my. So this was a very interesting video. Hope it plays. Oops. Okay, let me go back. Maybe you can hear this cough. I don't know whether you can hear because I don't think I shared my audio before I started. But these are coughs which are in very short bouts. So you'll have a long inspiration thing and you'll go. This is the type of cough that you get. This video was very interesting, but unfortunately, I don't know why it's not playing. But there's a kid who went on doing. That's how she used to cough. So this is something called as a habit cough syndrome, and it is really, really on the rise, and it's a troublesome disorder because, and it is very oftenly you have these kids who come with loads of inhalers or something with them because they've been diagnosed as asthma. But the classical presentation is a harsh, barking, repetitive cough that occurs for several times per minute or hours at end, and it is absent in sleep. So you distract the child, the cough disappears. When you have a cough which is like of this nature, and especially if there's a stressor, like in this kid, it was a COVID in the father, please do think of a habit cough. Let me take you to another case. And handling these children is a Herculean task because here you have to counsel not only the child but also the parents that this is not a pathological cough and it's just a psychological aspect to it. And it really takes an effort to go about that and convince them. Sometimes you have to do a whole lot of investigation just only to convince the parents that it is not pathological. Now, 11-year-old male child has coughed since 1 month. This is dry cough, fever since 3 to 4 days, no history of breathlessness on and off, no weight loss or any other complaint, no cox contact, no asthmatic on prophylaxis with inhaled budesonide since 1 year. So 11-year-old was reasonably well controlled and now has come with fever and cough. And this time the cough is going on for a month. Okay. Or when he came to the emergency department, he clearly had respiratory distress and his saturation was 92% on room air. He was conscious, cooperative, but he could not speak full sentences at the time. He had an expiratory wheeze. So he was admitted, treated like an acute exacerbation of asthma, and he was follow up. He was followed up after 3 days after discharging him, but he still had wheeze and still had mild respiratory distress on follow up, and therefore he was worked up. At this point of time, his hemoglobin was 13.4. If you know his history, that in between he kept getting these episodes of fever, breathlessness. So he was investigated and a CBC done, showed a eosinophil count of 8.2, an absolute eosinophil count of 1057. ESR was normal, and this was his X-ray. If you look at this X-ray, you see you see consolidation here in the right upper lobe. So these are classical mucus pluggings, which are called as the finger glove appearance. And CBC was showing eosinophilia. We further investigated this child. We did an IgE, which was more than 1,000. We did a skin prick test for Aspergilla, which was positive. So this is a classical case of allergic bronchopulmonary aspergillosis. So ABPA will come on children who have uncontrolled asthma, or maybe asthma becomes uncontrolled when you have further sensitization to aspergillus. And ABPA is also seen in children with cystic fibrosis. So if you have an ABPA, look for an underlying cause as well. You may be having an uncontrolled asthma or a cystic fibrosis, which was now diagnosed. And sometimes you may give all the possible correct advice to these children. You may even look at the techniques, but parents are very, very innovative and they can do what they feel is right. And therefore, it's very important when you give inhalers or you have uncontrolled asthma, apart from looking at triggers, comorbid conditions, please do not forget to look at their techniques. Please do not forget to look at their adherence, right? Now, this is an 8-year-old recurrent rhinorrhea, cough. I think I will, after this case, I've just jumped to the next case and stop because I think my time is getting over. 8-year-old with recurrent rhinorrhea, cough, otitis media, lower respiratory tract infections, and with fever from infancy. No family history of asthma. He was a 32-weeker, 1.6 kg, not ventilated, managed only with supportive care. So, 8-year-old recurrent infections, otitis media and lower respiratory infections. And this is coming with fever. So this is not like allergic rhinitis or asthma. And he had adenoid faces, and chest always showed crepes and wheeze. So initially he was thought to be an asthmatic and he was put on inhalers, nasal corticosteroids, but he did not improve. And then a spirometry was done. So it's a very important test to do when your diagnosis is in doubt, which showed evidence of restrictive disease with no post bronchodilator reversibility. And hence this child was investigated, and we thought in terms of a mucociliary disorder in this kid. The sweat chloride came normal, genetic studies for CF came normal, and his ABG electrolytes, sputum were all clear, immunoglobulins and immunodeficiency workup, tuberculosis was obviously ruled out. And we did a electron. This is an old patient of mine. You can see the date going back to 2015. This was the time we were not really doing much of genetics for PCD. So we did a brush biopsy, and that showed rare, only few cilia with rarely discernible dynein arms. So this was a child with primary ciliary dyskinesia. This is my last kit, and I will just run through it. These are rare cases, but I thought it's good to share. 4-year-old, 8-month-old child, third degree consanguineous marriage, and came with cough and shortness of breath since 1 year. And in the last 1 year, she was admitted multiple times for so-called lower respiratory tract infection. Each time she had cough with breathlessness. She was full term, no NICU stay, developmentally normal, family history non-contributory. Now this kid was very tachypnic and saturation was 93% on 10 liters of oxygen on a non-rebreather mask, and she had a pectus excavatum deformity. Air entry was decreased bilaterally. So something is going on. So this is a child who's hypoxic and has a pectus excavatum deformity, meaning something which is happening from very early in life, right? And we did an X-ray. This was not a normal X-ray. You can see fine reticular shadows bilaterally, almost occupying the whole of the left lung, sparing just the right upper lobe, but is also occupying the left lung. So something happening probably in the interstitium, probably at the alveolar level. We did a CT which showed something called the classical crazy pavement appearance. And you say crazy pavement, this interlobar, intralobular septal thickening, ground glassing. This is what was seen. And this is characteristic of something called as pulmonary alveolar proteinosis. The pulmonary alveolar proteinosis is a syndrome complex. There are many reasons why you will get alveolar proteinosis, and this is just a syndrome complex. So this child was further worked up for the alveolar proteinosis, and we got a genetic cause for her, which was a defect in the surfactant metabolic protein. When you have a surfactant protein dysfunction, so it's called a surfactant pulmonary surfactant metabolism dysfunction. Here we got a mutation which was pathogenic and which was in the colony stimulating factor 2RA, meaning on the macrophages in the pulmonary tissue. The macrophages, the function is to clear off the used surfactant. But when they have to clear off the used surfactant, there is a place on the surface of the macrophage where a binding has to occur. Only then the macrophages can clear off the surfactant. So this is a defect in that binding protein which binds to the surface of the macrophages, and hence used surfactant continues to block the alveoli, and which causes the clinical features of breathlessness and cough and a higher requirement of oxygen. So the palliative treatment for this is whole lung lavage. This is what we have done as a team, where we wash the child's full lungs, we remove the milky fluid, the typical past positive fluid, which is because the lipids of the surfactant which are there inside the macrophages as well as outside the macrophages in the lung. Once you wash the lung, the child will feel better. But this child has undergone a stem cell transplant and is doing well. So we have to be very important is taking a good history. Find out how severe is the cough. Find out is there an underlying disease. Find out if it's a non-serious cough, an asthma syndrome, or it is a overestimation or a psychogenic cough. So these are, I think, if you look at cough in these 5 lights, you will definitely come to a conclusion what is the cause of the cough of your child. You should also look at the growth charts. Is very, very important, because any child who's failing to grow has something serious underlying. you can use some cough syrups, antihistaminics as required. But nowadays the recommendation says no dextromethorphan below the age of 4 years. And cough suppressants, I mean, there's no point in using a khichdi of cough syrups, like which contains an expectorant as well as a suppressant. So yes, if your child is wheezing, you please do use a bronchodilator. The preferred route to use it is an inhaled way, but maybe the first time you may use an oral bronchodilator till you can convince the parent. You may use antihistaminics, either first or second generation. Second generation are non-sedating and hence preferred, especially if you have children with allergic rhinitis, some amount of viral URI, who may need some antihistaminic. But mind you that these antihistaminics also have a rebound phenomena and may make the children very, very irritable. And I definitely use some cough suppressants like dextromethorphan for children who have cough, which is really, really troublesome. About the age of 4 years, you can definitely use some cough suppressant, but you be mindful of what you're using and use it in the correct dose. Because most of these coughs are self-limiting. Of course, some are not, and there you may need the role of some of these cough syrups in correct doses for the correct age groups. And counseling is very important, and it's one of the most cost-effective method of treating these children with cough. Thank you so much for the patience. There any questions? Abhinaya, are there any questions in the chat box?
Can I start my presentation, ma'am?
Yeah, just 1 second.
Yes, ma'am.
I'm just looking if there are any questions. Feel free to put the questions in the chat box, even if you have not asked now, and we can keep answering you on the chat box, right? Yeah. And now will call upon Dr. Abhinaya to take a talk about her presentation. They've asked some question. 1 year old child coughs. Which should we use a cough syrup? The answer is nowadays actually not recommended at all in a 1 year old child. You can use a bronchodilator if the child is wheezing. I would request you for the want of saving time, please put your questions in the chat box and we will answer. I call upon Abhinaya to now start her presentation on approach to wheeze in children, which will again be a case-based discussion.
Thank you, ma'am. Good afternoon, one and all. I'm Dr. Abhinaya. I'm doing my Pediatric Pulmonology Fellowship in Narayana Health SRCC Children's Hospital. Today, we shall going to discuss briefly about how to approach wheezing in children. It's a case-based approach. So first, what is a wheeze? So wheeze is nothing but it's a continuous high-pitched whistling sound which is accompanied by prolongation in the expiration phase. This wheezing sounds originates in the large and medium-sized airways because of the oscillation, because of the turbulent airflow in a partially blocked intrathoracic airways. And it is generated either because of the narrowing of the airways due to bronchospasm or due to airway secretions. Is it audible? Yeah. So wheeze is basically a whistling sound which we hear in the expiratory phase. Now we shall see various respiratory sounds. So this is the strider which we commonly parents get confused. The noisy bits they all come with. This is the strider. Striders are actually originated in the glottic region. Inspiratory strider is seen when the pathology is extrathoracic and intrathoracic strider is actually expiratory. So now we shall see other common airway sounds like snoring. So this is snoring. Now we shall see how the wheezing is like. So normal wheezing which we hear in asthma patients are polyphonic. What does polyphonic mean? So polyphonic, it means multiple airways of different lengths are constricted and which produces a whistling sound. When only one of the airways is constricted, for example, in a foreign body or some lesion obstructing one airway, what we hear is the monophonic wheeze. Why this slide is important is for us to differentiate the abnormal respiratory sounds produced in a child, and this is very important. So the next other commonly used interchangeable terminology is rhonchi. We often hear these words wheezing and rhonchi together. But what is actually a rhonchi? Rhonchi is nothing but a low-pitched wheeze and is caused by airway narrowing because of the secretion. And this is continuous nature and biphasic. I shall play the rhonchi sound. So now we have seen what wheeze sounds like and what rhonchi sounds like and what does polyphonic wheeze sound like. So now let us approach different cases of wheezing. So first case is a 7-month-old girl, full-time LSAS, birth weight of 3.8 kg, came with complaints of cough cold for 3 days, fever for 2 days, and fast breathing for 1 day. Mother has an upper respiratory tract infection, and a child is very irritable and not feeding well. On examination, child is well-grown child. Child has tachypnea with subcostal retractions, saturation 94% in room air, and auscultation. We hear bilateral wheeze and crepitation. Rest of the systemic examination is normal. So we have done a chest X-ray. Chest X-ray is showing bilateral hyperinflated lung fields and increased bronchovascular markings. So what will be a diagnosis? So this is a typical, this child is actually a first-time wheezer. So this child, the diagnosis is a viral bronchiolitis. So the viral bronchiolitis, it's most often is caused by the viral infections like RSV, human metapneumovirus, parainfluenza, and rhinovirus. And this is a first-time wheezer. So how will we manage a bronchiolitis? What is bronchiolitis? It's nothing but a viral infection in the respiratory tract leading to mucus buildup, and there is necrosis of the epithelium, and there is smooth muscle tightening causing collapse of alveoli, and in the rest of the lung there is hyperinflation. The treatment of bronchiolitis only hydration and humidified oxygenation. This child responded in phase. So what is important for us to know with this case is bronchiolitis, there is no role of antibiotics and steroids. Some children may require bronchodilators, but there is doubtful role of bronchodilators. And when we should refer a child with bronchiolitis? So we have different categories of bronchiolitis. We should refer when the child is not feeding, when the child is cyanosis, when there is severe respiratory distress, or the child with heart disease and preterm children. They all require proper hospital-based management. Now we shall see another case. This is a 3-year-old boy presented with recurrent dry cough with wheezing and requiring nebulizations. All these episodes are like without fever, and the child gets episodes once in every 2 months, lasting for 7 to 10 days. And the cough does not settle even when the child is completely better. And he also coughs in between the episodes also when he is running or he is laughing, and there is history of atopic eczema in infancy. So now what do you think this child has? So as we all understand, this child has a very typical history of preschool wheezing. But how shall we start inhalers in a preschool children as asthma is diagnosed after the age of 5 years? So we have an approach called the GINA-based probability-based asthma diagnosis. So GINA 2024 gives us guidelines when to start inhaler in a preschool wheezing. So this is based on the probability of having asthma in the future. So first category of patients are few have asthma. So when they have symptoms of cough, wheeze, heavy breathing for less than 10 days during an upper respiratory tract infection, and the episodes are only 2 to 3 per year, and in between the child is absolutely well, which means episodes are of shorter duration and the child is having 2 to 3 episodes per year. So all these children, they have very few probability of having asthma in future. In the second category, some have asthma, the symptoms are lasting for longer duration, more than 10 days, and the episode also more than 3 episodes per year, or if the episodes are severe enough requiring hospitalization, ICU admission, or if there is a night worsening of symptoms. Between the episodes, child may have occasional cough, wheeze, or heavy breathing. So these children, if we follow up till 5 years, some may have asthma. And the third important category is most have asthma, where the symptoms are also for longer duration. Most severe episodes are more than 3 episodes per year. And very important clue here is between the episode, child has cough, wheeze, or heavy breathing during play or when laughing. And the child also has allergic sensitization, atopic dermatitis, or other allergies, or if there is a family history of asthma. So all these children, if we follow up, most may persist to have asthma in the future. So based on this probability, we can start inhalers in children. So our case is fitting into most have asthma. So if we see there are some red flag signs, this should alert our antennas, and then we should think that they may not be a preschool wheezing. So what are the red flag signs? If the wheeze has started less than 6 months of age, if they have any localizing or unilateral signs, if they have a localized wheeze, or if the symptoms are non-variable. So asthma is a kind of a disease where they have reversible symptoms and they have variable presentation. If they have a fixed symptoms, it may not be asthma. If they have a persistent wet cough, so asthma typically has dry cough. If the child has persistent wet cough, maybe we are not dealing with asthma. If the child has fever or poor weight gain, or if the child has clubbing, persistent hypoxia, other system involvement, and very importantly, poor response to bronchodilators, then we should start thinking about other diagnosis. So now let's see how to manage wheeze. So what is wheeze? As we discussed in the first slide, wheezing is actually caused by the bronchoconstriction and there is edema in the airways. So how shall we manage the bronchoconstriction is by giving a bronchodilators. So there are three important types of bronchodilators, which is the beta-2 sympathetic mimetic, which is salbutamol, terbutaline short-acting, and the salmeterol, formoterol are typically the long-acting ones. We have the anticholinergic ipratropium, thiotropium, and methylxanthines. We don't use aminophylline category of drugs now because of their very narrow therapeutic index. And then we have other set of medication which will control the inflammation part. The leukotriene receptor antagonists, montelukast and zafilokast, they have very poor efficacy compared to corticosteroids. Corticosteroids are again our systemic inhalation. And the last one is a combination of the ICS and then the LABA drugs. So now let's see how to manage our patient. So any patient with wheezing less than 5 years, detailed history and examination is very important. And we have to rule out atypical signs of wheezing as we have discussed our red flags. If all those red flags are ruled out, then we have to treat children with some category and the most category of asthma. So we will not treat few have asthma. So we'll start with a trial of inhaled corticosteroids. The dosage is budesonide 100 microgram twice daily with a spacer and a mask. And then we have to evaluate the child in 4 to 6 weeks. In 4 to 6 weeks, if the child has good response, we continue the ICS for next 3 months and then we stop abruptly after 3 months and we watch for recurrent symptoms. If the child has recurrent symptoms, we start the ICS again. If the child did not respond in the initial follow-up 4 to 6 weeks, then we are not dealing with asthma and we have to refer the child for further evaluation. So this is the GINA guidelines. I'll just quickly say step one is nothing but infrequent viral infection. We just give intermittent SABA. SABA is nothing but short-acting beta agonist, which is our salbutamol and levosalbutamol. We typically start with low-dose ICS in step two. If the child is not responding, then we can double the low dose of ICS. If still not responding, we have to refer our child to a specialist. We may not be dealing with asthma. We have to revisit our diagnosis, their inhaler technique, adherence, and exposure to trigger during each and every visit. So ICS dosage in children under 5 for budesonide, the low dose is still 200 micrograms per day. The medium dose is 200 to 400 microgram per day and high dose is more than 400 microgram per day. The fluticasone dose is similar, which is almost less than half. of our budesonide dose. And usage of formoterol is not recommended in children less than 5 years. And for children, we always prescribe inhalers with a spacer. For children less than 3 to 4 years of age, we are using MDI with spacer and mask, and make sure the child is forming a tight seal with the mask. After 3 to 4 years, if the child is able to directly use a spacer, use only spacer and do not use the mask, as mask will decrease the absorption of the inhaler medicine. And even for an adolescent and adults, it's advisable to use MDI with spacer. So now let us see few mimicas of preschool wheeze. Case number 3 is a five-month-old boy born out of third-degree consanguineous marriage. Child was born full-term LSA's birth weight of 2.3 kgs, cried immediately, no NICU stay, immunized, presented with noisy breathing from 1 month of age. Now the child had cough and increased respiratory activity going on for last 2 months. Child was treated on OPD basis with all bronchodilators, nebulization, and oral steroids. On examination, child had heart rate of 140. Child was tachypneic with suprasternal and subcostal retractions. Saturation was maintained. Child had typical biphasic stridor. In auscultation, child has had wheeze with stridor. So because the child had noisy breathing, stridor, and wheezing, and with not gaining weight, we had done a bronchoscopy in this child. So if you see bronchoscopy, we are seeing the epiglottis vocal cords going into the airways. What we are seeing is there is collapse of the trachea. So what is this? Actually, it's the tracheomalacia. What does tracheomalacia mean? It means there is abnormal collapsibility of the trachea during a respiratory cycle. For example, if there's a more than 50% compression of the trachea during inspiration and expiration, then we call it as tracheomalacia. The cause can be either primary or secondary. Primary means intrinsically the trachea wall is very soft and pliable, or it can be secondary because of an extrinsic vascular compression. Symptoms are typically a biphasic stridor, expiratory, and then the child can present with dyspnea more during any infection, and child can present with acute life-threatening episodes. The diagnosis is by bronchoscopy, where they have more than 50% luminal narrowing, and the treatment depends on the severity of the symptom and the cause. If the child had alti episodes, parents have to be taught about CPR and chest physiotherapy. If there is any external vasculature compressing it, then it's surgery. Very severe cases might require CPAP and internal stents and tracheostomy. And sometimes in all these patients, even bronchodilators may even worsen the tracheomalacia and worsen the stridor. Case 4 is a 4-year-old boy, known case of autism spectrum disorder, presented with cough since 10 days, fever for 2 days with increased respiratory activity for 1 day. On examination, he was tachycardia was there, saturation was 95 in room air, no pallor clubbing, and but whereas when he auscultated, air entry was completely reduced in right side, was a monophonic. This again, apparently completely reduced in right side with monophonic wheeze. We had done an X-ray. What we see in X-ray is nothing but the right side is looking small. There is right side lung volume is reduced, and then there is crowding of ribs in the right side. We were thinking in terms of foreign body. So when we did the bronchoscopy, we saw a foreign body in the right mainstem bronchus. So we actually found out a peanut in the right mainstem bronchus. We then retrospectively asked parents, and then they were like, yeah, he was having peanuts, but we never thought he choked up. So sometimes these aspirations are not noticeable. So this foreign body, as ma'am said already, this requires suspicion, and then bronchoscopy really helps in diagnosing foreign body. And very importantly, foreign bodies can have monophonic wheeze. Sometimes they can have bilateral wheezing, reduced air entry. They can present in different manner also. Another case is an 8-month-old girl, full-term LSCS with birth weight of 2.6 kg. Presently, she was weighing only 5.3 kg. Cough and cold was there for 3 days. Fever low grade. Fast breathing for 2 days. Child was not feeding well, and there was history of recurrent cough in the child. On examination, child was febrile, heart rate of 170, tachycardia was there, tachypnea was there, SCR and intercostal retraction, saturation of 92% in room air. In auscultation, there was bilateral extensive wheezing, no murmur heard, and there was liver 3 centimeter pulpit. We had done an X-ray only to find a huge cardiomegaly. We couldn't hear the murmur, probably because the child had extensive wheezing. We did a 2D echo. There was a moderate subaortic VST. So where sometimes murmur can be missed, it's because of the background extensive wheezing or sometimes even very large VST. The intensity of the murmur can be very low. So it's very important for us to rule out important causes like congenital heart disease in a child with wheezing. Next case is a 5-year-old boy. He was in a full-term normal delivery, birth weight of 2.9 kg. He presented with recurrent cough since 6 months of age. The cough was initially dry and then later the cough was wet in nature. There was no history of recurrent cold or ear infection. The child was started on inhalers for recurrent cough. We examined this child. The child was underweight. The child had grade 1 clubbing. As we discussed earlier, clubbing is not seen in asthma. So this is another red flag. And child was vitally stable. And respiratory examination showed bilateral wheezing. And cardiovascular examination showed heart sounds were heard on the right side, which means child had dextrocardia. So we have done an X-ray, which again proved the child had dextrocardia, increased bronchovascular markings, some early changes of bronchiectasis were seen. So we were thinking in terms of primary ciliary dyskinesia, genetic workup for SEN, and which came positive for primary ciliary dyskinesia. So the typical red flag here is the presence of clubbing, not gaining weight, and wet cough. So primary ciliary dyskinesia typically presents with recurrent wet cough since early infancy, with recurrent ear or recurrent cold. But this child didn't have, and some children may not have recurrent cold or ear infection. Even though this child had dextrocardia, the diagnosis was missed for the last 5 years. So we did something called as nasal NO, and we also did something called as a high-speed video microscopy at SRCC, where we are able to see the dyskinetic cilia movement in the nasal epithelium, which is confirmatory of the diagnosis. So it's very important to rule out uh, wheezing and then think of atypical diagnosis when our child has red flag signs. So this is a quickly, we are just going to summarize and see the differential diagnosis of preschool wheezing. The child can have recurrent infections. The child can, small children like infants, they can also have recurrent cough because of GER. They will present with recurrent chest infection. They vomit easily, especially after large feeds, and they have poor response to asthma medicines. We also saw foreign body. Pertussis is an again important diagnosis where they have protracted paroxysm of coughing, often with stridor vomiting, especially seen in infants. PBB, we see PBB is a diagnosis which we make when they have a persistent wet cough for more than 4 weeks, and all other diagnoses are ruled out. Tracheomalacia we discuss. TB we all know it's endemic in India. We diagnose TB when they have fever and with other signs like decreased weight loss and then with contact of TB and poor response to bronchodilators with enlarged lymph nodes, congenital heart disease, all these things have to be considered. Another important diagnosis is cystic fibrosis. These children, they present with recurrent chest infections, recurrent wet cough, failure to thrive, loose, bulky stools. Sometimes they can also have constipation. So presence of failure to thrive, recurrent chest infection, all these things we have to think in a child with wheezing, this may not be asthma. Children with vascular rings, they all can also have persistent wheezing of the blockage, external compression of the airways, and they also respond poorly to asthma medication, which is an important pointer that it is not asthma. As we all know, BPD, immunodeficiency, they also can present with similar recurrent episodes of wheezing. So all these things has to be considered in mind, and always remember and look for atypical findings. Now we are going to see another case. He's a 9-year-old boy. So we have crossed the preschool wheezing. Now we are going to see a school-going children. 9-year-old boy now presented with recurrent cough and cold. These episodes were once in a month. The cough was in the form of dry cough, more at night time with awakening. Each episode lasts for 7 to 10 days. Occasionally, child had breathlessness relieved with nebulization and history of cough while playing games. And there was no fever during episodes, and there was family history of asthma in mother. On examination, his examination only revealed, respiratory examination revealed prolongation in the expiration. So what do you think is the diagnosis? So this child history is typically suggestive of asthma. Asthma is actually a clinical diagnosis where they have variable symptoms showing a reversibility, and all these things are pointed towards asthma. So how will you diagnose asthma clinically? When they have symptoms of cough, recurrent episodes of cough, wheezing, breathlessness, which and they did, and they don't have fever during these episodes. If there is history of any allergy, atopy, or if there's a family history of atopy, and then the symptoms are worse in the nighttime, or if the symptoms gets exacerbated on stress or playing, or if you are able to find some trigger for the symptoms, if there is seasonal variation, and if there is any relief with bronchodilator. But we have something called as a pulmonary function test, which help us to objectively see if the child has asthma. So what do we do in PFT? In PFT, we ask the child to blow hard forcefully. So what important, I'll just quickly discuss how to read a PFT. So first, we will see the FEV1 by FEC ratio. The normal ratio is 90 for children, it is 77, which means it has reduced and there is obstruction. FEC, forced vital capacity is normal, 97%, but FE is low, 85%. So we have given bronchodilator for this child, and we were able to see 23% reversibility post bronchodilator, which is suggestive of asthma. Any change more than 10% or 12% in adults is suggestive of asthma. So this child had obstruction with reversibility. So, asthma is the clinical diagnosis, and spirometry with bronchodilator reversibility provides objective diagnosis of asthma. So, whenever we diagnose on initial presentation and during an every visit, we have to assess the control of asthma and the risk of future exacerbation. How to assess the level of control? So, we have to ask only 4 questions. So, in the last four weeks, did the child have daytime symptoms more than twice a week? Were there any night awakening due to asthma? Did the child require any reliever for more than twice a week, or was there any activity limitation due to asthma? For all these 4 questions, if the answer is no, then the child has well controlled. If the child has 1 to 2 of these, which means it's a partly controlled, and if all 3 or 4 are positive, it means uncontrolled. We use this test even in the beginning of the diagnosis because it helps us. Pardon? It helps us to tell whether the disease is well controlled, partly controlled, or uncontrolled. After knowing the control of the disease, we also look into comorbidities in children with asthma. Because all these comorbidities will hamper our asthma control. Presence of obesity, gastroesophageal reflux, rhinosinusitis, adenoid hypertrophy, obstructive sleep apnea, atopic dermatitis, and other allergies like allergic conjunctivitis. All these things have also been equally addressed while treating asthma because these can worsen the underlying asthma. So, how to start treatment of asthma in 6 to 11 years old? So, we have to go stepwise. For example, if the children are having symptoms less than 2 days a week, we start children on low dose ICS and whenever SABA is taken. For example, whenever the child has symptoms, ICS and SABA are given together intermittently. If the child has symptoms 2 to 5 days a week, then low dose ICS is started plus SABA as needed. SABA is nothing but short acting beta agonist, which is salbutamol or leosalbutamol. The children are having symptoms on most of the days or waking at night once or more than a week, then we start on low dose ICS LABA combination or medium dose ICS plus as needed LABA or very low dose MART. I will explain MART in some time. And step 4 is when the child has a low lung function, we actually refer for expert advice and start on medium dose ICS LABA. So this treatment is initiated according to the GINA guidelines. So the first step is we are going to give ICS and LAB and SABA whenever the child has symptom. In step 2, we are going to start on low dose ICS and start on SABA whenever the child has symptoms. So in the alternative, what we see is the daily LTRA. Daily LTRA is nothing but daily Montelukast or Zafirlukast, and they have very inferior potential to treat asthma as compared to corticosteroids. So we can use this alternatively only in parents who are very apprehensive on starting the inhaled corticosteroids. Otherwise, they have very less action as compared to ICS. So, and the step 4 and 5 is always better to refer to expert for further management because these children may require further evaluation of phenotyping of asthma. Some of them may even require biologicals. So the ICS dosage in children between 6 to 12 is the Budicort low dose is 100 to 20, medium dose is 200 to 400, and high dose is more than 400 microgram per day. And what is MART therapy? MART therapy is single maintenance and reliever therapy. So this terminology is only used for inhalers which contain budesonide and formoterol. The main principle is formoterol is fast acting and it is a long acting. So the same inhaler is used when the child as a reliever and as a controller. For controller also the child has been given the same combination, and when the child gets symptom the same inhaler is used. This is called as a single maintenance and reliever therapy. This is advocated for children more than 12 years, and between 6 to 11 years this can be given based on, but there are very few studies supporting MART therapy and it is not recommended for children less than 6 years. The advantages, there is significant reduction in the exacerbation, and then there is reduced oral corticosteroid dose, and there is better symptom control. But be careful before prescribing a MART therapy, as there are very few data supporting in children between 6 to 11 years. The next case which we see is a 10-year-old child, known case of asthma on inhalers, presented with acute onset breathlessness. On examination, child had tachycardia, tachypnea with subcostal retraction, saturation of 21% in room air, and air entry reduced with Wheeze heard in expiration. So now we understand this child with asthma has presented with an acute exacerbation. How will you assess and manage an exacerbation? So we have something called as a pulmonary score, very easy score, which helps us in categorizing the patient with asthma and also helps in monitoring the patient with asthma. This requires only three things: respiratory rate, wheezing, and the accessory muscle use. Saturation you can consider for managing. This has only three things. So for children less than 6 years, less than 30, the score is 0, and it increases from 15 15. 31 to 45 score is 1, 46 to 60 score is 2, and more than 60 the score is 3. And then for children with less than more than 6 years, it starts with 20. When the wheezing is not present, scoring is 0. If it's terminal, score is 1. If it's expiratory, score is 2. If it's throughout the respiratory cycle or a silent chest, the score is 3. And the usage of accessory muscle, if it's not there, it's 0. If it's questionable or very mild, it's 1. It's very apparent, it's 2. And its maximal is 3. Based on this, we scored the child. And between less than 3 is mild, 4 to 6 is moderate, and more than 6 is severe. So our child is coming in the moderate category. So now let us quickly see how to manage exacerbation of asthma. So any child coming with exacerbation, remember ABC, airway, breathing, and circulation. And child having any drowsiness, confusion, silent chest, immediately admit the child in ICU, start on oxygen, SABA, and consider further management. If no, then you can triage the child based on the pulmonary score as mild, moderate, and severe. So what for mild asthma flare up? So how to manage? If the in mild asthma flare up, the saturation is usually maintained. If the saturation is maintained, there is actually no need to give SABA through a nebulizer. We can give it through the inhale, through the MDI only. So whenever we can encourage the parents to use MDI at home, and we can follow the same thing in our ER. The child is presenting with mild exacerbation. We are supposed to give 4 to 10 puffs in 1 minute gam through MDI with spacer every 20 minutes for 1 hour. Watch for symptoms, observe for pulmonary score. The child has improved, you can reduce the frequency, add steroids at 1 to 2 mkd, maximum 40 milligram for 3 to 5 days, and please call the child for follow-up in 1 to 2 days. So for mild flare-up, you give only salbutamol and then steroids and then send the child home. If the child had presented with moderate flare-up, look at the saturation. If the saturation is more than 92, we again give inhaled SABA through inhaler only. So you can give 4 to 10 puffs with a spacer every 20 minutes for 1 hour, and please observe the child. Child is improving and not improving. If the child is improving and then going to the mild category, follow like a mild category. If the child is not improving and still persisting in moderate or severe, then act accordingly. If the saturation is less than 92%, then we start oxygen-driven nebulization. We give salbutamol through a nebulizer, which is oxygen-driven, uh, given 20 minutes and 3 doses back to back for 1 hour. Simultaneously, we start on oral steroids and then assess the child. We can also give ipratropium. If the child continues to have flare up for ward admission, what is required is only oxygen, IV or oral steroids, SABA nebulization, hourly or back to back. Nebulization ipratropium, we can give every 20 minutes only for 3 doses and monitor the oxygen and the pulmonary score. Other investigations are not required. We require CBC, electrolytes, and chest X-ray only to look for complication. Otherwise, other investigations are not required. Now, let us quickly see how to manage severe flare-up. Severe flare-up require PICU admission. They require oxygen. Two, we can either start an HFNC or NIV support and avoid mechanical intubation. And then please do a blood gas analysis. SABA can be started with an oxygen-driven nebulization. Ipratropium nebulization can be given, and IV steroids should be started immediately. Hydrocortisone 2.5 milligram per kg per dose 6 hourly, or methylprednisolone 1 milligram per kg per dose 6 hourly. Injection max self you can give, but only 1 dose. The dose is 25 to 50 milligram per kg, maximum 2 grams, slow infusion over 30 minutes. And there is no role of adrenaline, terbutaline, or aminophylline infusion according to the GINA guidelines 2024. If the child has still not responded, then you can mechanically intubate the child, but please avoid intubation. Many of the children, they do recover well with the HFNC or the NIV support, and they require volume control respiration with low RR and low tidal volume. And take care of the hydration. If the child is not responding, complications because of asthma like air leaks, atelectasis, or an alternative diagnosis. Lastly, we will see one case. This is the last case. 6-year-old boy, well child, presented with cough, cold for 5 days, fever for 4 days, fast breathing for 1 day. On examination, he was febrile, heart rate of tachycardia was seen, mild tachypnea, saturation was 94% in room air. On auscultation, child had bilateral wheezing and crepitation. So this is fitting like a viral picture. We had done an X-ray to find a patch in the right middle lobe. But in bacterial pneumonia, wheezing is not usual. So this should raise an alarm because wheezing and patch. So we have to think of atypical pneumonia. So we had done a BAL in this child and mycoplasma was isolated and this child was treated with azithromycin. So summary, so what is important is we have to diagnose asthma and then should also rule out the child is having any atypical signs and symptoms to look for alternate diagnosis. So there are few 10 commandments how to arrive at the diagnosis. First question when you see the child, what is the onset of wheeze? Is the wheezing sudden, acute or subacute? Sudden, think in terms of foreign body. Acute, you can think in terms of infection, and subacute or recurrent. Is the cough dry or wet in nature? What is the timing of cough or wheezing? Is it in the daytime? Is it the nocturnal? Nocturnal cough or wheezing is mostly seen in asthma. Frequency of cough, whether it's variable or whether the symptoms are persistent. Triggers, is there any viral infection, seasonal change, is there any precipitated by exposure to smoke, activity, duration, and how long does the cough or the wheezing takes to settle? And what are the interval symptoms? Is there any weight gain or are there any associated other systems involved? For example, in cystic fibrosis, child may present with recurrent loose stool, greasy stools. They may also have other symptoms. Is there any personal or family history of asthma atopy? And did the child respond to nebulizer or what did the child respond? All these 10 questions will help us arrive at the diagnosis. This is a quick, chart of what we discussed in the last half an hour. So when the child comes with cough, please see the onset. Is it sudden? Is it gradual or chronic or intermittent? If it's sudden, look for other coronal symptoms. Is there any viral prodrome? Think in terms of viral lower respiratory tract infection. If there are no viral infection, if it's sudden, think in terms of foreign body. If it's gradual onset of wheeze from late infancy or early childhood, if the symptoms are intermittent or it is recurrent or it is persistent, it helps in giving us the diagnosis. Please suspect asthma when the child has typical symptoms, or if the under 5, please use the probability based diagnosis of GINA. If the child has chronic intermittent symptoms, see how has the child been in between the symptoms. If there is any associated stridor or anything, think in terms of tracheomalacia, think in terms of vascular compression. And the type of cough is also very important. If the child has persistent wet cough, then we are not dealing with asthma and something else. So it's very important for us to remember the 10 questions which we discussed earlier and all the red flag signs, which helps us in differentiating wheezing because of asthma and because of other causes. Thank you. Thank you so much. Any doubts? Now I invite Dr. Tanvi Modi to present on antibiotics in respiratory tract infection.
Good afternoon, everyone. So thank you, Abhinaya. Thank you, Indu ma'am, for that very enlightening talk to at least help us approach Wheeze, approach cough. I will not be going so much into detail about each and every condition, but I want to focus mostly on the rational antibiotic practice in pediatric respiratory infections. The reason that we're covering this topic is because all the cases that we have seen in Dr. Indu ma'am and Dr. Abhinaya's cases, everyone must have received some antibiotic at some point or the other. So we really need to see the rationality of using antibiotic, whether it was really indicated or not. Why is this so important? It's because antimicrobial resistance has been declared by WHO as one of the world's top 10 global public threats. It has been declared a silent pandemic on a global health crisis. There are multiple causes of antibiotic resistance. One of the most common ones is the overprescribing of antibiotics. The CDC has seen more than 35,000 deaths happening because of antimicrobial resistance, and 5.2 million deaths in the Western Pacific have been predicted by 2030. A Lancet study of the last 20 years has predicted a mortality of more than 30 in India and some South American countries by the year 2050 if the current trend of antimicrobial resistance continues. So, now that I've got your attention, hopefully, I'll come to the burden of respiratory tract infections in our country. Findings from NFHS 5 in 2019 to 21 showed that 56.1% children had sought treatment for an acute respiratory infection in the 2 weeks preceding the survey. The prevalence of respiratory tract infections remained almost unchanged between NFHS 4 and NFHS 5, that is in those 7 years. And respiratory tract infections remain a major public health challenge. So now let's see why it's so important in our pediatric practice. Respiratory tract infections are obviously the most common presenting complaints in our OPD. They are one of the most common causes for hospitalization and under 5 mortality. The distinction between viral, bacterial, atypical etiology is not always easy. And though most infections are of viral origin, different age groups, they present differently and they have a different set of pathogens which may be characteristic to that age group. Irrational prescribing of antimicrobials in viral respiratory tract infections has led to antimicrobial resistance and has put these 4 bacteria on the WHO antimicrobial resistance list in 2024, where group A streptococci have been seen to be macrolide resistant, strep pneumoniae has been found to be macrolide resistant, H. influenzae as ampicillin resistant, and group B streptococci with penicillin resistant. This is the spectrum of respiratory tract infections that we will see in our practice, ranging from upper respiratory tract to lower respiratory tract, from the common cold to severe pneumonias. We see it all. So when do we give antibiotics and when do we not? Now I'll take you through a case-based approach. We won't go through the management of each cases in detail, but we will mainly focus on whether antibiotics should be given, should not be given. If yes, then which antibiotic should be given and the duration. So let's start with our first case. All the cases need to be approached in this 4-pronged manner for early and accurate diagnosis, early and specific treatment, looking and managing any comorbidities, and then seeing if primary prevention by vaccines could be possible. So the first case is of a 1-year-old female child with a runny nose since 3 to 4 days. Initially, the fluid was watery, but now it's a yellowish in color. It has a dry cough since 2 days, fever up to 100 degrees since just the last 1 day, vitally stable, afebrile, chest is clear. What is the probable diagnosis? And does she need antibiotics? This is nothing but the common cold, which ma'am has already covered. It's infectious rhinitis or rhinosinusitis, most commonly caused by rhinovirus, which has more than 200 serotypes. HMPV, which is all the rage in the news nowadays, but actually it's not a novel virus and has been there around for the last 20 years. Influenza, parainfluenza, adenovirus. Each child has at least 6 to 8 episodes of the common cold a year, with 10 to 15 children having one every month, and it has absolutely no role of antibiotics. Our next case is a 3-year-old boy with runny nose, cough, and sore throat since 4 days, fever since 3 days, decreased appetite and myalgia. On examination, he was vitally stable, his throat looked like this, there was rhinorrhea, but systemic examination was normal. Our clinical diagnosis here, and do we need antibiotics? Our clinical diagnosis here is nothing but pharyngitis. Pharyngitis is one of the most commonly treated conditions with antibiotics, especially amoxicillin and clavulanic acid. But how do we differentiate it? Bacterial versus viral, with the most common bacteria being group A streptococcal. Viral will usually be following a prodrome. There will be coryza, there will be a cough, there might be conjunctivitis, especially if it is adenoviral. There could be hoarseness, it may have diarrhea, there could be discrete ulcerative lesions, there will be myalgia, there may be a typical viral exanthem, and there could be either posterior cervical or generalized lymphadenopathy. Streptococcal infection, on the other hand, will be a sudden onset sore throat with high-grade fever, a sick-looking child. There could be nausea, vomiting, headache, abdominal pain. There will be erythema of the pharynx and the tonsils. There might be patchy discrete exudates. There will be tender anterior cervical lymph nodes. There will typically be a history of contact, and there could be typical features of scarlet fever. One confusing condition could be when you see a throat like this, which is exudative pharyngotonsillitis. EBV, infectious mononucleosis, can be difficult to differentiate from group A streptococcal infection, as both can have exudative pharyngotonsillitis. How do we differentiate between it? A CBC in infectious mononucleosis will characteristically have lymphocytosis, and the peripheral smear may show some atypical lymphocytes. EBV slide agglutination test or a multiplex PCR, which is rapidly available, might be performed to confirm the diagnosis, both of which are expensive. And since most viral etiologies have no specific management, there is actually no role in doing so. But when we have a strong suspicion of streptococcal infection, we have a score called the modified Centaur or the Mac-Isaac scoring. This gives 1 point each if there is no cough, if there are swollen, tender anterior cervical lymph nodes, if the temperature is exceeding 100.4, if there are tonsillar exudates or swelling, and if the age is 3 to 14 years. A point is deducted for patients 45 years or older. The cumulative score gives a predictive value of the risk of a group A streptococcal infection. The way to proceed from here is if the cumulative score is more than or equal to 4, there is a 51 to 53% chance of a group A streptococcal infection. And in these cases, we will proceed to just take a throat swab, a throat culture, or a PCR to confirm the group A streptococcal infection. Even if we get a score of more than equal to 4, there's only a 70% chance of confirming group A streptococcal infection. So it's not 100% predictive, but definitely has a role and has a higher chance of coming positive if we have a higher suspicion. The reason to highlight this is because most untreated episodes of group A streptococcal pharyngitis also resolve uneventfully within a few days. Then why do we need to give antibiotics, you all may wonder. We give antibiotics because it hastens the clinical recovery by at least a day or 2 days. Children can resume school earlier, parents can resume work earlier. There's a reduced chance of complications like peritonsillar abscesses, cervical lymphadenitis. But most importantly, primarily the role of antibiotics is to prevent acute rheumatic fever later in life. This is most effective if the antibiotics are started within 10 days of onset. This again tells us that we don't need to rush to start Augmentin, amoxiclav in the first 3-4 days of presentation. We can wait to see how the disease progresses and we can start antibiotics even after 3 to 4 days if there is no improvement. But on the other hand, if we have a high suspicion of group A streptococcus, we have tested for it and we have a confirmed diagnosis, we should not delay antibiotic therapy. Please note, antibiotics do not prevent acute PSGM. They are mainly for prevention of acute rheumatic fever. Now, which antibiotic do we give? If there is no penicillin allergy, oral penicillin B, 250 mg twice a day for 10 days, or oral plain amoxicillin, 50 mg per kg, divided in 2 divided doses, or a single dose based on different guidelines for 10 days. If there is penicillin allergy, if it is an anaphylaxis or type 1 hypersensitivity, we can give cephalexin or cefadoxil. If it is not a type 1 hypersensitivity, we can give clindamycin, azithro, or clarithromycin at these doses specified, and the dose is at least for 10 days unless it is azithromycin. Our next case is an 8-year-old boy presented with runny nose, cough since 5 to 6 days. Nasal discharge is thick and yellowish. He has a headache, especially around his eyes and his forehead. He had fever 3 days ago, which is now subsided. And on examination, we get typical tenderness over the forehead, over the cheeks, with a purulent nasal discharge. He's maintaining saturation, chest is clear, there's no respiratory distress. So what do we suspect and will you give him antibiotics? You can feel free to reply in the chat box. This can be interactive. Right, it is acute bacterial sinusitis. It's most commonly sinusitis is viral rhinosinusitis as a complication of the common cold. Only 6 to 7% of viral URTIs will be complicated by acute symptomatic bacterial sinusitis. The most common bacterial pathogens are Strep pneumoniae, H. influenzae, Moraxella catarrhalis, and rarely Staph aureus. Primary prevention by the pneumococcal and the H. influenza B included in the National Immunization Schedule have definitely decreased their incidence. But approximately 50% of H. influenza and 100% of Moraxella are beta-lactamase positive. This can guide our management. Another clinical clue about sinusitis is if we remember the age that the sinuses develop. A 2-year-old versus a 6-year-old coming with these complaints, we can decide which sinuses are formed. Like the frontal sinus only develops by the age of 7 years. The ethmoidal and the maxillary sinus, though present at birth, only the ethmoidal sinus is pneumatized. The maxillary sinus gets pneumatized only by 4 years of age. So this can again give us a clue towards the clinical diagnosis. Sinusitis is essentially a clinical diagnosis. X-rays, CTs will show thickening of the mucosa. They may show obstruction, but will not guide us completely towards the etiology. It is unnecessary unless there is persistence of the symptoms and there is no improvement. Now, how will we treat sinusitis? We suspect sinusitis, as I said, if there is persistent symptoms of rhinitis for more than 10 days without improvement. If there is a sudden worsening or new symptoms after initial improvement, or if there is a severe onset with a high temperature of more than 102 and purulent nasal discharge for 3 to 4 consecutive days. The major symptoms, as I mentioned, are besides all of these, facial congestion, facial fullness, pain, hyposmia, anosmia, fever for acute sinusitis. It could also have headache, dental pain, fatigue, depending on the radiation. All of these symptoms will need antibiotic. Now, if you keep in mind the etiology, we can understand which antibiotics to give. Initially, our empirical choice will be amoxicillin clavulanic acid or a high dose amoxicillin for 10 days because Streptococcus pneumoniae may be resistant. Penicillin allergy can be treated with levofloxacin or cefpodoxim. Severe infections or complications may have vomiting, they might require hospitalization and IV antibiotics. We start with injection ceftriaxone. If the child improves, then we switch to oral antibiotics to complete a duration of 10 days. If there's no improvement in 48 hours, we might have to consider changing the antibiotic to levofloxacin or add ampicillin sulbactam, refer to ENT, look for complications like abscesses, or we might need to do a drainage for microbiological evidence. The total antibiotic duration should be at least 10 days or at least for 7 days after the symptoms resolve. The complications that I had mentioned are either orbital, periorbital cellulitis, meningitis, subdural empyema, brain abscesses, osteomyelitis of the frontal bone, which will require IV ceftriaxone and also vancomycin or metronidazole if you have a suspicion of an abscess. Please remember, azithromycin and trimethoprim sulfamethoxazole are no longer recommended because of a very high prevalence of antibiotic resistance. Please do not give azithromycin when you're suspecting acute bacterial sinusitis. Our next case is a 1-year-old girl presented with a runny nose since 4 days, fever since 1 day, about 100-101. She's irritable, rubs her ear frequently, and cries when anyone touches her ear. On otoscopy, we see a congested, bulging tympanic membrane, and on examination, vitals are stable, chest is clear. Our diagnosis here is acute otitis media, a suppurative otitis media. Again, this is mostly bacterial. Streptococcus pneumoniae, H. influenzae, and Moraxella are the characteristic pathogens. H. influenza AOM may be associated with conjunctivitis. Few viruses like rhinovirus, adeno, influenza, and RSV may be a cause of AOM, especially in children in daycare settings, but they seldom present alone. They usually have a superadded bacterial infection. AOM is a known complication of bronchiolitis, and if it's not treated adequately or properly, mastoiditis, chronic suppurative otitis media, intracranial complications can occur. How do we treat acute otitis media? This is the decision to treat depends on the age of the child, the severity of the infection, the laterality, whether it's unilateral or bilateral, and whether you think the parents will comply to treatment if you send them home on an OPD basis. This is the guidelines by the American Academy of Pediatrics and also followed by the Indian Academy of Pediatrics that for children less than 6 months, I'll run you through the algorithm. This is a bit simpler. The initial management of a normal child with uncomplicated AOM from 2 months to 12 years. For less than 6 months, you will always treat with antibiotics with either high dose amoxicillin or amoxiclav or cefuroxime, or if severe infection, IV ceftriaxone. In the period of 6 months to 2 years or above 2 years, first you will see if there is severe disease, whether there's severe rotalgia, whether there's high grade fever. If there is, then you will treat with amoxicillin or amoxiclav. If it's not a severe disease and if you are certain about the diagnosis, then again you will treat with antibiotics. However, if it's not a severe disease and you're not confirmed about the diagnosis, if there is no middle ear effusion, if all the signs and symptoms are not fitting, you can wait and watch. There could be observation for a 48 to 72-hour period. The caregiver must be very vigilant at home, must know the warning signs, and must have immediate access to the clinic if there is any deterioration. Similarly, for above 2 years, we follow the same algorithm. If it's severe disease, we will treat it. If it's not severe, whether or not our diagnosis is certain, we can wait and watch if we are confident about the caregiver's compliance. The duration to teach, I'm sorry for this, the duration to treat for a younger age group is at least 10 days, older children maybe 5 to 7 days. The next case is of a 3-year-old boy. Fever and runny nose since 2 days. Acute onset of barking cough, exacerbated on running or crying, active and playful in the interfebrile period when he's not coughing. On examination, I'm sorry, the slides seem to have hung. There seems to be a yes, we're back. On examination, there's an inspiratory stridor, mild rhinitis. The diagnosis here is essentially a spot diagnosis. There is some kind of upper airway obstruction, and our differentials are actually a long list. There could be a supraglottic or intraglottic obstruction, and based on the symptoms, we can differentiate. It's more likely to be a supraglottic if there is drooling of saliva, a soft stridor, but it's a toxic looking child with high fever. It's most likely to be intraglottic if there's a barking cough and significant stridor. The most common differentials that we may face are epiglottitis in supraglottic and laryngo-TB or CRU in intraglottic. Foreign body, bacterial tracheitis, retropharyngeal abscesses, or diphtheria are also seen. Diphtheria is less now because of immunization. So I'll run you through the 4 common differentials. Retropharyngeal, bacterial tracheitis, and epiglottitis are usually sick-looking children with high-grade fever. They might have a minimal cough, whereas in CRU, it's a well child. There's a harsh stridor, a loud cough. The X-ray neck is not necessary to establish diagnosis. It could be used as a supportive treatment. The main reason to highlight it is CRU is mostly a viral etiology only, with the most common virus being parainfluenza 3, whereas the other 3 have bacterial etiologies like H. influenzae, strep pneumoniae, moraxella, and rarely staph aureus, our favorite 4, which require IV antibiotics. They are medical emergencies and require stabilization. IV ceftriaxone plus or minus vancomycin or clindamycin. CRU, as I said, most commonly by parainfluenza types 1 and 3, which account for more than 75% of cases. Others may be influenza A, influenza B, adeno, RSV, measles, metapneumonia. The takeaway from this is CRU is a clinical diagnosis of viral etiology. Management is based on severity, and there is no need for antibiotics. There's a Wesley Crew severity score on the basis of which we can divide into mild, moderate, severe, or impending failure based on the level of consciousness, cyanosis, stridor, air entry, and retractions. The management is essentially dexamethasone, oral if it's taken, otherwise injectable. There is a variable role of epinephrine nebulization in moderate cases and a definite role in severe cases. There is a role of hydration, oxygen in moderate cases, but there is no role of antibiotics. Our next case is a 4-year-old male child with fever since 7 days, wet cough since 1 month, but no history of any tuberculosis or weight loss. He's a well-grown child, hemodynamically stable, maintaining saturation, no clubbing, cyanosis, lymphadenopathy, and on examination, he has occasional Krebs bilaterally. What is our clinical diagnosis? This is an entity that Dr. Indu ma'am has already touched upon called protracted bacterial bronchitis. We should suspect it if there is a wet cough lasting more than 4 weeks and all other causes are ruled out. There may or may not be fever. The child is going to be well grown, which rules out immunodeficiencies and other chronic issues. The most common pathogens identified are strep pneumoniae, H. influenzae, Moraxella, and rarely Staph aureus, our favorite four. And it responds to 2 weeks of antibiotics, most commonly is amoxiclav. The diagnosis may be microbiological based or clinical based. As in regular practice, we might follow the clinical base. It may not always be possible to get microbiological diagnosis. But if you have a cough not responding, a wet cough not responding for 2 weeks, then please refer to a center to get sputum or bowel for a microbiological diagnosis. We might need up to 4 weeks and further investigation. Our next case is a 6-month-old female child with bouts of cough since 2 weeks, exacerbated on crying, followed by vomiting, fever since 2 days, which is just mild, and fast breathing since 1 day. The child is unimmunized. She's tachypneic, tachycardic, and this is a giveaway that there's an inspiratory whoop following a bout of cough, which is a kind of air hunger, facial congestion, and examination may be clear. Our clinical diagnosis, this is a spotter, it's pertussis. Management for this child is a no-brainer. It is azithromycin as the drug of choice for all age groups. It also has to be given promptly to all household contacts, irrespective of their immunization status or symptoms. Primary prevention is essential by vaccination against pertussis. The next case is a 10-month-old boy with cough and cold since 5 days, fever since 1 day, fast feeding since the morning, decreased feeding since the morning. On examination, he is pink, tachycardic, tachypneic, saturation is 93% on room air, and there are bilateral bronchi, mild subcostal retractions. This is a wheezer, as we've already discussed in Dr. Abhinaya's lecture. How will you manage this case? The severity, the first thing is to assess the severity. Is it mild, moderate, or severe? Depending on the child's ability to feed, respiratory distress, or room air saturation. After we've assessed the severity, our treatment is mostly going to be supplemental humidified oxygen, clear the nasal passage, give adequate hydration because there will be a decreased oral intake, manage the fever if there's any. There is no proven role for bronchodilators, adrenaline nebs, or hypertonic saline nebs. And there is no proven role of steroids, sedatives, antibiotics, or decongestants. Our takeaway message is for bronchiolitis, irrespective of the severity, unless you're suspecting a superadded bronchopneumonia, there is no role of antibiotics. The most common etiological agent for bronchiolitis is viral, especially RSV. Our next case is a 4-year-old boy with high-grade fever since 4 days, fast breathing, abdominal pain, decreased activity and oral intake since 1 day. He's sick looking, tachycardic, tachypneic, 102.8 degrees temperature, and not maintaining saturation or room air. Air entry is decreased over the right inframammary region. What is our probable diagnosis here? This is a pneumonia. How do we identify the etiology of a pneumonia? Viral again will follow a coryza or a prodrome. It will follow the seasonal pattern. There will be contacts with similar complaints. The prominent complaint will be cough. There may or may not be a wheeze. Child will be non-toxic, could be active in afebrile periods, and mostly there would be diffuse or bilateral findings. A bacterial pneumonia may not have a prodrome. There will not be coryza. There will be tachypnea, which is the hallmark of pneumonia. Bronchial breathing, focal signs, and a localized disease are characteristic, and the child will be sick looking with high fever. Once we've identified the etiology, how do we approach a child with community acquired pneumonia or CAP? Empirical antibiotics will have to be started because of the high burden of mortality due to pneumonia. We cannot wait for a microbiological diagnosis because blood cultures have only a 10 to 15% yield for the organism in a pneumonia. Sputum cultures and throat swabs have a low reliability. They may pick up carriers, commensals, which may not accurately represent the etiology of that infection. It's not always possible to do invasive procedures like BAL for all pneumonias. So we have to start antibiotics. We choose the antibiotic based on the age and the age-specific pathogens and presentations, as I told you earlier, the severity of the infection, and the specific pattern or organism if we identify like Staph aureus. Now, going through the age-wise typical organisms and the antibiotics that are needed, neonates are characteristically, the etiology in neonates is characteristically group B streptococcus and gram-negative bacilli, besides our favorite strep pneumoniae and H influenza, which along with penicillins and cephalosporins will need an aminoglycoside. Between 1 to 3 months, viral etiologies are predominant besides strep pneumonia H influenzae, which will be covered with beta-lactams if we isolate them. If it is viral, it needs no antibiotic. Atypical organisms are rare in this age group. 4 months to 5 years, again predominantly viral etiologies besides our usual bacteria. Atypical like mycoplasma, even group A streptococci may be more common in this age group. They might need macrolides. Group A streptococci, strep pneumoniae, and H influenza will need beta-lactams. Above the age of 5 years, our organisms remain the same, with predominantly being bacterial, requiring beta-lactams. They might need macrolides, and if Staph aureus is suspected, they might need vancomycin or clindamycin along with the beta-lactam. For outpatient basis, less than 3 months child coming with a pneumonia should always be admitted. 3 months to 5 years, your first line would be high dose amoxicillin in 2 or 3 divided doses for 3 months right up till 12 years. Our second line would be amoxiclav, cefpodoxime, cefioxim. Above 5 years, they might require macrolides. And for suspected staphylococcus, we can add on cloxacillin. For admitted patients less than 3 months, as I told you earlier, along with our beta-lactams like cefotaxime, ceftriaxone, we have to add on amikacin or gentamicin to cover the gram-negative, piperacillin, tazobactam, or add on cloxacillin if we suspect staph infection. 3 months to 5 years, the protocols are essentially similar, with ampicillin being our first choice, amoxiclav, cefotax, ceftriaxone, or azithromycin being our second line, and the protocol being the same for staphylococcal infections. With the amount that we have mentioned, our 4 bacteria and amoxicillin and amoxiclav, there is research done in the Indian Journal or the Journal of Indian Medical Association with only amoxiclavulinate acid, which I strongly recommend everyone should go through. It beautifully tells the formulations and more importantly, the indications in the US FDA and European Medical Association, which I have enumerated here, which we have covered in our talk, but this just summarizes it. Besides respiratory tract, it's also indicated in cystitis, pyelonephritis, skin soft tissue infections, osteomyelitis, and UTIs, which are suspected to be by beta-lactamase producing strains of E. coli Klebsiella. To summarize this whole thing is when to give antibiotics. What are the risks versus the benefits of treating pediatric respiratory infections with antibiotics? The benefits are, of course, we reduce the morbidity and mortality. There's no direct benefit in viral infections, although it may decrease the secondary bacterial infections. It often alleviates parental anxiety because oral antibiotics are believed to keep children out of the hospital, and they are cheap and easy to give, and unfortunately, many times are given over the counter in our country. The risks far outweigh the benefits if they're given unnecessarily. They increase antimicrobial resistance. There will be no antibiotic to give in case of severe infections if antimicrobial resistance progresses at this rate. And inappropriate empiric antibiotic use will give a false sense of security, which may delay an accurate diagnosis. So with that, I thank all of you, and I hope that this has helped in the rational use of antibiotics. Are there any questions? Thank you very much. I now invite Dr. Hiren sir to elaborate on chest X-rays and enlighten us in this masterclass today. Thank you.
So, a very good afternoon, and thank you for joining for today's masterclass. I am Dr. Hiren Panwala. I am a pediatric radiologist at SRCC Children's Hospital, and I would like to acknowledge Department of Radiology at SRCC as well as the CMC Vellore Hospital where I did my training. So today, what we are going to do that I'll just show the basics and approach how to read pediatric chest X-ray. Am I audible? Just if I'm audible, just put in chat yes or no so that I can go on. Am I audible? Okay. So somebody mentioned yes. So before we start, how to read pediatric chest radiograph, let's do some sort of exercise. You have been given two radiographs side by side. Do you think both are normal or something is abnormal in one of the X-rays, and what are the findings? You can put in the chat box. And just for your clarity, the X-ray which is on the right side, that is of a infant X-ray, probably a neonate, and the X-ray on the left side, it is 2 years old X-ray. So Anybody wants to mention anything, like anything you're finding abnormality in either of this X-ray? You can put down in the chat box, then we can start describing it. Anyone, both are normal or something is weird? So just for the interest of time, I would like to say that when you are looking at the chest radiograph, always try to see the upper abdomen also. So those who had seen the X-ray carefully, they would have noticed that a large gas shadow is seen on the right side of the upper quadrant, which is the stomach shadow. Usually the stomach shadow should be seen on the left side, as we can see on this radiograph. But here we can see that the gas shadow is seen on the right side, and the cardiac apex is towards the left side. So both cases have levocardia, but you can see that the liver shadow on the right side of the X-ray shows on the left side, which is not normal. So the first X-ray is of so for the first X-ray represents situs solidus, in which you will see that the normal arrangement of the abdominal organs, and the right side X-ray represents heterotaxis syndrome, in which you can see that various abnormalities or various type of arrangement of the organs inside the abdomen as well as in the heart. So it's very important when you are looking at the radiograph, please see in toto, look at the bones also, and look at the upper abdomen. For example, this was a nice pickup if you would have noticed. So the question is that how do you want to look at the chest X-ray? You want to see like this way, in which you have a very focused or tunnel view, or you want to have this kind of panoramic broad view. So anybody wants to put down in the chat box how you want to see? So the correct answer should be that when you are reading a chest X-ray, you should have always panoramic broad view. You should see each corner of the X-ray. Sometimes there might be fracture or some body lesions which might be seen in the shoulder radiograph or something. If you don't carefully see, then you can miss. So the first take-home message from this today's talk is avoid tunnel vision. So these are some sort of frequent challenges that we observe when we are reading at the pediatric chest radiograph. First of all, the basic question comes that whether it's a thymus or it's a mass. That is the one common question. Recently, only yesterday, only at our hospital, Dr. Nihal Shah had come with one pediatric radiograph in which there was some sort of opacity in the right side of the pedastinum, of which they were not sure whether it's thymus or mass. Then we'll see how to solve those kind of situations. And you should be aware about the potential mimickers. Is there any infection? And if you find some sort of differential lung density, then which is abnormal and which is normal, or is there any pleural effusion, empyema, or pneumothorax? So these are the common thing that you should be able to identify, and you should be able to tell the pitfalls related artifacts also, right? So just to be starting with the basics, that on X-ray, those tissue which has got which are least dense, for example, air has least density. So they will be seen as a black thing because all the X-rays would have transmitted, and that would have absorbed by the X-ray film or the X-ray film, so that it will be seen as a black thing. And those tissue which has maximum density division, for example, metal or for example bone, they will absorb the X-ray, so they will be seen as a white thing on the film. So just to be a common knowledge that air will be seen as a black, fat will be some sort of gray zone. Your calcium, bone, X-ray contrast, and metal, they will be seen on the whiter spectrum of the film. So these are the basic things that you should be aware about. Then you should be aware about the normal arteries. And whenever you are reading radiograph, you should start from either periphery to center or center to periphery. So you can go either way. It's not a thumb rule, but you should cover all the aspects when you are looking at the chest radiograph. So here is the normal chest radiograph frontal view, in which we can see that we'll start with the central to periphery. So this is the trachea and the bifurcation of the it's bifurcation at carina. That is the right main bronchus, is the left main bronchus. Right main bronchus is slightly more steeper than the left main bronchus. That you should be knowing. And this is the right side paratracheal shadow, which is caused by the asthma vessels, the SVC light there. Then there will be one rounded shadow, which will be the insertion of the azygous vein into the SVC. So that is the round shadow caused by the azygous. That is formed by the bright atrium on the frontal radiograph. Then on the left side paratracheal region, you will see some sort of aortic knob kind of thing, that is the arch of aorta taking a turn and forming a descending aorta. Just below that, you will see a shadow, which is the main pulmonary artery shadow, which will divides into right and left branches and intra-abdominal branches. Then followed by, you will have this left cardiac border, which is formed by the left cardiac, left ventricle. And in the lung fields, you will see these kind of vertical channels which can branch further. That is the descending pulmonary artery on the right side. This is the dome of the diaphragm. Dome of the diaphragm should have this kind of normal concavity. If it is flattened, and if you draw one arbitrary line from the CP angle to the midline, and if this exertion from the midpoint of the dome of diaphragm, if it is less than 1 centimeter, then you can say that there is some sort of flattening of the diaphragm which can happen secondary to hyperinflation of the lung. So that you should be aware about that. You will expect this kind of normal concavity of the diaphragm. These are the clavicle and bones. And another difficult thing is how to read the lateral radiograph. So here with the nomenclature, we can see that in the central area, you will be seeing the hilar region. You will be seeing some sort of two gas-containing channels. So the anterior one will be the trachea and the posterior one will be the esophagus in that two gas-containing channels. And in the anterior and middle mediastinum, you will see this kind of hard shadow that will be posterior to the sternum. Immediate posterior to sternum, you will see this kind of lucency which is caused by the overlapping lung, which is a normal thing. And when we go from top to bottom in the spine area, the density should become more lucent, because here you will see that there will be overlapping shoulder and scapula, those kind of bones which will be seen as more dense tissue. But as we go lower down, there is no overlapping bone. So you will be seeing that normal lung lucency overlying the vertebral spine. So as a thumb rule, when you go from top to bottom, the blackness or the lucency should increase. If it is getting replaced by some opacity, that means that the patient might be having like pneumonia or mediastinal lesion. That we can confirm by CT scan or by looking at the frontal radiograph, right? So these are the diaphragmatic dome in which we can see that the right lobe of diaphragm will be continuous and the left lobe diaphragm will be incomplete. So that is about the lateral radiograph. Then you might be wondering about when to say cardiomegaly on the chest radiograph. So first of all, when you are laboring cardiomegaly, you should be aware about the patient has taken normal inspiration. And usually we identify normal inspiration when we count the anterior ribs of the affected side. If we can see that if normally the 6 anterior ribs should touch the mid dome of diaphragm. So if you see that kind of radiograph in which the 6th rib anterior end is touching the mid dome of diaphragm, that is normal inspiration film. So in that way, you can assess whether the patient is cardiomegaly or not. And since the chambers enlargement can be asymmetrical in those kind of scenario, you can take from the midline vertebral spinous process to the right side maximum diameter and to the left side maximum diameter. And you can accumulate A plus B, that will be the transverse cardiac diameter for that patient. That should be divided by the transverse internal thoracic diameter at the 9th or 10th intercostal inner margins. And if that ratio is more than 60% in children, that is considered as a cardiomegaly. And in infants, especially if it's more than 65%, then it is considered as a cardiomegaly. Then you should be, this is more of a radiology related thing, that you should be aware about the exposures. So when you have some sort of underexposed film in which you will be able to see more vessels in the parenchyma, so that can give rise to diffuse granular opacity, those kind of appearance. So generally, the vessels are seen in the central two-third of the area. When they are seen in the periphery also, that means that the exposure is not proper. It might be underexposed film. When you are taking radiographs, you should be aware about the external objects which can cause artifacts. For example, here, 12-year-old girl had come for the X-ray checkup, and she forgot to tie her hairs, and what we can see that the hair braid related artifacts which are superimposing on the lung field. And if we are not aware, or if we don't have knowledge about that thing, then we could label it as a mass or consolidation. But you can see that that density is going upward and going left side also and going outside the body also. So that indicates that it's some sort of external thing, not in the lung fields, right? So in that way, you can ask the patient and then repeat the radiograph by properly tying the hair, and then we can see that opacity was outside the lung, it was external thing, right? It makes a lot of difference when you take the film in proper inspiration. For example, here is one of the patients who had come to our hospital, and the patient had some history of wheezing and suspected foreign body, those kind of situation. But if you and at that time, this was the initial radiograph, and if you see that initial radiograph, there is hardly proper inspiration in this film. You can see that only the fourth rib is touching the anterior diaphragm. That means that it's an expiratory film. So if you take the expiratory film, you will have this kind of diffuse ground glass opacity in the entire lung. You might see that the patient has cardiomegaly also. So this kind of potential artifacts you can obviate when you do proper inspiratory radiograph. This was the same patient after doing proper inspiration. You can see that those kind of consolidations or ground glass opacity has resolved. So that we can clear the doubt. Another important thing that you should be aware about is the thymus. So the thymus can be variable size. It can be seen on right side, it can be seen on left side, it can sometimes seen on lower part of the chest, sometimes upper part of the chest. So and especially less than 2 years, the thymus can be of it can occupy even the 2/3 area of the entire chest cavity. So the size doesn't indicate it's abnormal pathology. The appearance and the surrounding structural relation that makes a difference whether it's a normal thymus or an abnormal mass, mid-axial mass. So when you see this kind of sharp lateral and inferior border, which is surmounting with the cardiac margins, so that indicates it's anterior or middle mid-axial mass, and the lateral radiograph you can see that this is that triangular shape opacity, which is very homogeneous. Other thing that thymus being soft structure, you will be able to see its underlying vascular markings when you are looking at the radiograph. So that will be another clue towards it being normal thymus. And the normal thymus doesn't displace adjacent structures. So the trachea and adjacent ribs, the intercostal space, they should remain static and they should be comparable on either side. So in that way, you can say that it's a normal thymus or abnormal thymus. So these are the two different variety of thymic tissue. As I was mentioning, that thymus can have variable sizes, and here we can see that if you are not aware about normal radiographic finding, you can label this patient as a cardiomegaly or a large mid-axial mass. But as we have carefully seen that thymus have sharp, very well-defined lateral border, and they have this lateral and inferior very sharply defined margin. And if you can see underlying lung vascular markings through it, then it's a normal thing. And they can have this kind of sometimes gentle waviness along the lateral margin. That is also a normal finding, which should not lead to that it's abnormal thymus, right? And the trachea should be on its location. It should not be compressed or it should not be displaced towards opposite side. So that's a normal thymus. So this is called as Sale sign, in which you are seeing that sharp lateral and inferior margin, that is the Sale sign. And when you see this kind of gentle waviness of the lateral margin, that is called as a wave sign, right? So these are all normal thymic tissue. When you have doubt, we are not sure that whether we are dealing with consolidation or thymus tissue or a thymic lesion or any other mid-axial lesion, you can always use USC. USC is non-radiation modality, and you can easily make out the normal thymus has this kind of tiny dot and dash kind of appearance when you see the anterior intestinum, and in that way you can see that it's a normal thymus without any obvious mass lesion or any other pathology. On the contrary, when you are dealing with some sort of consolidations or collapse, you will have fuzzy lateral margin. It will merge with the surrounding tissue without any sharp margins as seen here, and they will have underlying some alveolar sign, and they will merge with the underlying bronchoscopal shadows. So in that way, we can differentiate consolidation versus the normal thymus. When you have some sort of hemometastasis, then we can see that air outlining the thymic tissue. So here we can see that this soft tissue shadow is the thymus shadow, and the large pneumometastasis is uplifting it from the heart shadow. that we can see this also. This is the heart shadow, and this is the large air within the mediastinum, which is uplifting the thymus. So this is known as swing maker sign because it mimics the swing maker. That's why the nomenclature has been formed for that. So when you are dealing with radiograph, first of all, you should try to see the lung parenchyma, then you should have focus toward vascularity. You should see the vasculature on either side symmetrically, upper zone, mid zone, lower zone. You should see heart, whether cardiovascular is there or not. But before that, you should see proper inspirator and techniques because the AP radiograph also can cause spurious mediastinal binding and can cause cardiomegaly, which is not true. And you should finally focus towards airway and mediastinum and bones and soft tissue. So you should see these all things when you are trying to read as a the pediatric radiograph, right? So we'll see some sort of examples of unilateral lucent lung via some radiograph and subsequently what we did and we try to sort out the issues. So here is one of the case in which the child had respiratory distress at birth, and what you are seeing that numerous cystic lucency in the left side of the hemithorax. What it is doing the shift of the mediastinum and heart towards the opposite side. And you can see the other important thing that you should always see the lobe diaphragm. On the right side, we can continuously track the lobe diaphragm. On the left side, we are not able to see the lobe diaphragm. So that means that there might be some sort of discontinuity or pathology of the diaphragm. So that was a case of congenital diaphragmatic hernia, in which we can see that the small bowel loops had migrated upwards. And usually CT scan is not needed, but this child also had cardiac issue for that CT scan was done, and which confirmed that it was a large posterior bobtail variety of the congenital diaphragmatic hernia, which was showing. Then you can have a well-defined cystic lucency in one part of the lung. So this was the case in which you can see that diaphragm was intact, but you can see a well-defined cystic lucency in the left, mid, and lower zone. So the differential of this finding would be either we are dealing with some sort of congenital cystic lesion like a CPAM or a CLO, which is congenital lobar overinflammation, and then CT scan was done for that, and CT scan revealed that the patient had abnormal cystic-looking malformed lung in that region. You can see that in addition to that large cyst, there were numerous variable size cysts were seen in that same lobe. The large cyst was showing this kind of air and fluid levels. That means that it was showing some sort of recent infection. This was the case of CPAP, and these are some CT reconstructed images showing the pathology pattern that we can see it is affecting the left lower lobe with some numerous cystic lesions within it. So the left lower lobe was resected and came out to the mixed variety of CPAP. When you are looking at the radiograph and the child had sudden onset Wheeze on the left side, and what we can see that if you carefully notice that the vessel margins on the left lower and mid zone appears to be less as compared to the right side. So that looks like more of a lucent area in the left, mid, and lower zone, which indicates that there is some sort of hyperinflation secondary to maybe proximal obstruction that can be a common possible mechanism. And at 2 years, we all know that is the age where you can find foreign body injection. So this was a child who had injected foreign body, and that was causing this kind of lucency in the distal lung and proximal obstruction. You should be knowing that organic foreign body may not be seen on radiograph. So that's why you have to see carefully to look at the secondary signs of the airway obstruction. And if you are in doubt, you can do always the lateral decubitus radiograph of the same side, because when you put the child in that dependent position in which you are suspecting abnormality, if you put on the left side dependent, then the lung should collapse, lung should show reduced volume. And if there is a pathology or obstruction which is fixed, then it will maintain that hyperlucency or hyperinflation in that area. So that will be another indirect sign that there is luminal obstruction in that affected area, which could be a foreign body. So this was the left main noctus foreign body which was removed. here is another example of a 10-year-old child who had fall from the horse, and child had came with respiratory distress, in which we can see that uh, uh, when you see unilateral hyperlucency, you should always see that are we dealing with some sort of pneumothorax or those kind of etiology, because considering fall from horse, that should be the first thought that when you see this kind of lucency, that if the child is having pneumothorax. So if you carefully see that this is the chest wall, and there is a sharp vertical lining from the lung parenchyma to the chest wall. So this sharp vertical line, that is the visceral pleural line, that is 100% specific for the pneumothorax. The other way, when you have this kind of abnormal lucency or blackening in the radiograph, you should always try to see some sort of vessel markings. When you are not able to see any vessel marking in that black lucent area, that also says indirectly that the patient has pneumothorax. But if you are able to see the vessels, then it could be just a hyperinflated lung. There were a few other findings in this child that there was some sort of air leakage into surrounding tissue, which was leading to surgical emphysema in the chest wall, which was also extending into the neck region. So that was the case of post-fall pneumothorax plus surgical emphysema. The other finding which we can see when the child is in the PICU, at that time you will not be able to see the visceral pleural sign because the child is on the supine position. So that line may not be seen, but in that kind of scenario, when you are in child in supine position, then the air accumulates near the CP ankle. So you will see unusual translucency of the CP ankle, and that will be more inferiorly placed as compared to the opposite side. So that and your that diagram also will be seen as more lucent as compared to opposite side. So these are the findings that will be seen when you have supine pneumothorax, right? So this is the CT of that same child who had fallen from the horse, and these are just confirmatory finding that the child had a large pneumothorax as well as the surgical emphysema. Unfortunately, that the child also had developed this kind of post-traumatic fluorosis within the lung parenchyma. The rupture of this fluorosis can give rise to the pneumothorax. Right? The advantage of doing CT scan that we can find some coupled linear fractures which are not seen on radiograph. So in this patient, we can see that there is a sharp linear lucency in the rib, which is indicative of a fracture. Here is another congenital cause of abnormal lucency. You can see that right upper and midfold shows abnormal lucent area, which is also expanding into the mediastinal shadow. So that is the hyper expansion of the lung, which is going into the mediastinum. And this is not pneumothorax. Why? Because you are not seeing any visceral pleural sign, and as I have indicated that you have to see carefully about the vessels shadows. So if you are able to see shadows within that lucent area, that means that it's a hyperinflated lung, but not pneumothorax. CT scan was done for the same, and CT scan revealed that that area was showing the hyper expansion or hyperinflation, and the vessels were looking smaller in size, attenuated as compared to the opposite side. And there was no proximal obstruction. So this was the case of congenital lobar overinflation. Before labeling as a congenital lobar overinflation, you should rule out other causes of the bronchial obstruction, which can be interluminal or it can be external, right? So that was the congenital lobar overinflation. Sometimes the child may present with this kind of abnormal looking large gas shadow in the mediastinum, which is very unusual, and the child might present with vomiting and all. So when you are in, and you are not able to see the stomach shadow in the left upper quadrant, so that can be clue that very rarely, not commonly, but the stomach itself can herniate inside the thoracic cavity. So this was the case. So when you have doubt about this scenario, always put a Ryle's tube, because Ryle's tube will go into stomach and that will confirm that this is a stomach shadow. So it was a high scenario in which the stomach had migrated to the thoracic cavity. So after dealing with that lucent lung, now we'll move forward towards how to deal with the unilateral opaque lungs, in which the common things are the pleural effusion, or it can be obstruction of the main bronchus, which leads to distal collapse, or it can be pneumonia affecting the wall loop on the one side. It can be a large pathologic tumor, or sometimes it can be pulmonary agenesis, which will give rise to the unilateral opaque lung. So we'll start one by one. Here is 2-year-old child with acute respiratory distress. Again, you can see that the left hemithorax appears to be completely opaque, but you can see that the heart and mediastinum is shifted towards the left side. If you see carefully that left brain locus, which is showing a sharp cutoff, like you are not able to trace the further branching of the left brain locus. So that indicates that there might be some pathology or some plug or foreign body at this location. So I might have given rise to the complete pneumonia or collapse of that area. So here you can see that this is the right main bumpus and the left main bumpus we are not able to see either. It is completely occupied by some pathology or foreign body. These are a few more CT scan which is showing the same finding. And the endoscopy was done, and on endoscopy it was found that the child had this kind of mucus cast, which was completely occluding the left distal main bumpus, and that was causing the collapse and pneumonia of the entire lung. So that was when you see this guy, the child who is febrile and comes with respiratory symptoms, when you see this unilateral shadow in which you are not completely sure that whether we are dealing with pneumonia or is there any coexisting pleural effusion or pleural empyema or some other pathologies, you can see that this kind of air bronchocollapse sign, which is the segmental bronchi division, which is the air outlining the subsegmental bronchi in the dense lung. So definitely the child has pneumonia, but is there any coexisting other conditions like pleural effusion or empyema? In those kind of scenario, you can use the ultrasound. So these are the ultrasound images of the same child, in which we can see that in the pleural cavity, the child had this kind of loculated pockets of pleural fluid, which looks like infected, and it is looking like more of an empyema formation because you can see these kind of dense low level internal liquors within it. So that indicates that it is probably empyema, which is a complication of pneumonia. So this kind of situation can be dealt by USC. When you are seeing a large shadow which is occupying the two-thirds or large areas of the hemithorax, then always, and the history is not acute, then always carefully see the surrounding soft tissues and bone. So if you carefully see here, this child, the right-sided fifth lateral part shows irregular areas of sclerosis and some light deficiency of the rib. You can see that abnormal soft tissue bulge outside the rib also. So that means that whatever that lesion, it is extending into the chest wall also, and which has got larger intrathoracic component. And in those kind of scenario, you can initially start with the USG. And on USG, the area was showing solid component. It was not looking like abscess. It was looking like proper a solid lesion, like a neoplastic pathology. And CT scan was done, and CT scan was revealing large lobulated heterogeneously enhancing mass. So that was having sarcoma of the rib, which was showing expansion soft tissue, and that rib was showing this kind of lytic and sclerotic area with the barriers to reaction. So in that way, you can proceed further, but you should have that suspicion that it is not just looking like some sort of pleural effusion or something. It is some more than that, because simple pleural effusion will not cause this kind of rib changes. Sometimes child will come with acute sickness and breathing difficulty. You should be able to identify the tension pneumothorax. So what you are seeing in the middle of the image, that is the tension pneumothorax, in which you can see that the right pleural cavity, it is expanded by this kind of free air, which is causing collapse of the underlying lung. So this kind of abnormal triangle shadow, that is the collapse lung. You can see that the air is expanding into mediastinum, also shifting the mediastinal shadow towards and the trachea towards the left side. So this is a tension pneumothorax. It's an emergency condition. We should immediately inform the clinician so that they can put the chest tube. So the chest tube was put and the pneumothorax was resolved. But this child was having recurrent pneumothorax even after putting the chest tube. In those kind of scenario, you should do CT scan just to look for why the child is having recurrent pneumothorax even despite of putting the chest tube. And we could find out that the child had very bad pneumonia, which has led to multiple nematocils and the consolidations, which were seen in multiple lobes. So they were not looking like a congenital thing. They were looking like more of a post-infective phenomenon. And the Klebsiella was positive for this test. So then you have certain conditions in which the child will have recurrent infection. So we'll be seeing some certain examples of those, how to deal with that. So here is one of the 15-year-old boy who had recurrent cough fever since early childhood. and you can see that in the right side, lower zone retrocardial region, abnormal triangular shape opacity, which is merging with the diaphragmatic shadow. When you see this kind of recurrent cough or something, you should always ask the child that whether the child had previous radiographs also. And if you see that pathology is persisting in all radiograph, and if it is near the diaphragm, then it might be a case of sequestration. And the CT scan was done with contrast. So whenever you are dealing suspecting sequestration, you should do CT chest with the contrast angiogram just to look at is there any systemic supply. In this patient, we can see that the abnormal collapse and the cystic area had systemic supply from the descending aorta that you can see here. So this was the case of intralobar sequestration. There are certain clue on radiograph which will help you to reach up to certain etiologies. For example, the last case scenario in which you should always see the older X-rays. If the older X-ray shows the same pathology in that same location, that means it has to be something like this congenital anomaly. So that can give rise to same persistence of the location. And if you are seeing that the anatomy localization is in the same location, then we might also have to know foreign body, or it can be some sort of congenital abnormality, or it can be vascular cause, which can lead to this kind of abnormality. When you see peribronchial wall thickening or bronchovascular thickenings, then you should rule out cystic fibrosis, asthma, ciliary are those kind of etiologies. The esophageal dilation is not usual. So when you see esophageal dilation in the radiograph, then you should be worried about that the child might be in fistula or a stricture or achalasia. When you see that the opacities or pneumonias, they are in different locations or different time, and they are multiple, then you should try to look out for the immunodeficiency or systemic cause. Then moving towards the airway, we can see that in the infants, this kind of normal tracheal buckling is a normal variation. You should not take it as a pathology because the cartilage of the trachea is also immature. The neck is shortened in infants, so these are the reasons why you can have this kind of tracheal buckling. You should not label it as a pathology. Sometimes you will see that generally the trachea has right-sided orientation, but when you see that trachea is shifted towards the left side, then you might be dealing with the vascular anomalies like in this case scenario, you can see that this is the right side aortic arch, which was causing unusual shadow on the right-sided parasternal and the superior intestinal area, right? Sometimes child may present with recurrent infection in stridor, and you will see some sort of narrowing in the airway. For example, here you can see that lower part of the trachea shows narrowing. For that, echo was showing some sort of perivascular cause, and CT scan was done, and CT scan was showing that this child had double aortic arch, which was causing narrowing of the lower trachea at the carina. And here you can see coronal view showing the same finding. You can see that is the carina, and it is getting compressed externally by the double aortic arch. And this is the 3D view of the same thing, is showing the same finding. You should always carefully see the skeletal system also. For example, here is the 13-year-old child with hypertension. So hypertension is a clue when 13-year-old child. And if you actually see that generally the aortic knuckle should go smoothly down, and here you can see there is a notch in the some sort of reverse free sign. And in those kind of scenarios, if you see carefully that the inferior margin of the ribs has got this kind of notching at multiple locations. I'll just show the zoom view that of the same patient that you can see this kind of inferior notching of the inner inferior aspect of the rib margin. So this is seen in coarctation of aorta. Sometimes you will see asymmetrical soft tissue opacities in the soft tissue surrounding the chest, in the chest wall. And those kind of scenario can be dealt further with USG or doing MRI to look at. This was a case of lymphatic malformation of the chest wall, which was showing this kind of low level echoes in it. On the medacinum pathology, we should be able to first of all identify abnormal medacinal contours from the normal medacinum on the chest radiograph, in which thymus is the one that creates troubles when it's normal or abnormal. And then we can recommend appropriate further imaging. For example, if you are suspecting Khosla medacinal mass, in which neuroblastoma is one of the more common pathologies, then you can go ahead with the MRI spine also. So first of all, our thing is that we have to differentiate normal from the abnormal. For example, here is the 8-year-old child, in 8-year-old child, you should not suspect thymus to be disposed of large. And you can see that there are some extra calcific or oxalic density within the radiograph. So that is abnormal. But you should be able to tell that this pathology is more towards the anterior or middle mediastinum because it is merging with the heart shadow. So whenever it is resulting with the heart shadow, that means that the mediastinal pathology is in the anterior or middle mediastinum. And CT scan was done, and which was revealing a teratoma, in which we can see that soft tissue density, fat as well as calcification within it. So by that, I would like to conclude today's session that we should be aware about proper technique of the chest radiograph. You should have a systematic approach how to go from central to periphery and cover each area of the chest X-ray. You should be aware about the hidden areas, for example, the retrocardiac region, for example, infraclavicular region, the bilateral shoulder set sometimes or humerus set and waist. And always carefully see about the history because whenever child has some kind of recurrent history of infection, and as we have seen that if localizing on the same area, then you might be dealing with some congenital. So by that, I would like to conclude today's session. And if there are any questions, I would be happy to take that. So if there are no questions, then we can ask the next speaker. Okay, so we are done with today's masterclass. I hope you must have enjoyed or learned some few teaching points in today's session. And if there are no questions, we can wind up. And thank you again for attending. And again, with next month, we will focus on another subspecialty or super specialty, and we'll gather the appropriate speakers. We'll get back to you with new information.